Well, hello everybody and welcome back to GU Cast. This is Declan Murphy, urologist here at Peter MacCallum Cancer Centre in Melbourne, joined as ever by my colleague Dr Renu Eapen. Hello Renu.
Hello Declan, it's great to be back. We haven't done this in a while.
I know, we've been on our summer holidays here in Australia. Yeah. We've had a nice January off. It's been good, hasn't it? You're all
great
refreshed.
Weather, warm, it's been good.
Yeah, COVID has of course surged. For those of you outside Australia, you've been used to COVID, but here in Australia we've had like almost no COVID for 2 years, but we have it now.
We've definitely got it now.
Sure do. And that's what January was all about. And we're ducking and weaving and trying to avoid it ourselves personally here.
Yeah.
But anyway, it's nice to be back after the summer break. We're looking forward to a fantastic 2023. It's going to be a great year, I think.
22. Not quite that 23.
Have I written off 22 already?
Yeah, it sounds like you have, Declan. But no, it's going to be a great 2022.
Yeah, I hope it will be a great 2022. And we wish you all the best for 2022. I think it'll be a great year in GU Oncology. It already is. We got ASCO GU coming in a couple of weeks. We already know there's some big papers coming at other meetings this year. There will be physical conferences. ASCO GU is physical. You're going.
I'm going
you've
in
got
a week. It's going to be,
Renu is doing
nervous excitement.
Yes. And what are you doing? You've been invited to do a talk in the Best of Journals section.
Yeah, the Best of Journals, the prostate cancer session. So I'm giving the urology point of view.
Excellent. I love that session.
Looking forward to it.
So you've picked 3 papers?
I've picked 3 papers. They're fantastic papers. And
and you're not
going to
you're not going to reveal here the 3 papers, but 3 great papers from last year that Renu has picked out that she'll present at ASCO GU in the Best of Journals section.
Well, I think we might reveal one of them.
Yeah, really?
Yeah.
It's up to you.
It's very exciting because we're interviewing the author today.
Okay, there you go. It's all out.
It's all out.
So we got a fantastic paper we're going to focus on today. And there, Renu has told you she's highlighted it as one of the GU highlights, top 3 highlights from 2021. And she'll talk about that at ASCO GU. But we're going to devote the whole podcast to it today.
Yeah.
So with that said, I suppose we should welcome our international guests.
Yeah, this is one that we've been wanting to do for a while, right?
Yeah,
right, Declan?
Because we kept saying this topic, which is
lymph node dissection in prostate cancer.
Yeah.
Age-old debate.
Yeah, perennial topic in prostate cancer, which is always contentious. Nobody can quite ever agree. Often dominated by a lack of good data to help us have the arguments. But this paper, this randomised trial that was published in European Urology Oncology a few months ago is certainly a really important trial to help us answer some questions about pelvic lymph node dissection. So that's our topic of the day. I suspect this podcast will lead to a couple more this year because we should talk about surgical aspects of the way we do high-risk cancer, especially a bit more because we know our audience are a lot of surgeons out there around the world and love talking about stuff that they literally see every day in and out of clinic and in and out of the OR.
And it's particularly important because, we've debated about lymph node dissection in prostate cancer for ages, but we've never really had any randomized controlled trials. And then last year we had 2.
Fantastic. So shall we welcome our international guests on Zoom? Yeah, it's a great pleasure to welcome Dr. Karim Touijer, attending surgeon at Memorial Sloan Kettering in New York and professor of urology at Cornell University. Karim, hello, welcome. Thank you for joining us on GUcast.
Thank you for having me.
Great to have you, Karim.
To be with you.
Yeah,
Thank you. All the pleasure is mine.
Oh, well, great one. Good evening to you in New York, and congratulations again on this fantastic trial that we're really looking forward to going through in some detail with you today. And as we saw last week, European Urology Oncology also recognized it as their top paper of the year, I think.
Best paper of the year last year. So that's congratulations, Karim. Yeah. Amazing work.
Thank you.
Great.
Thank you.
And also joining us from Belgium, old friend of ours, ex-Melbourne alumnus, Dr Wouter, Everaerts, consultant urologist at the Catholic University in Leuven, gigantic prostate cancer centre in Europe. And Wouter, or Wally as we tend to call him, we always called him Wally when he was here in Melbourne, is a consultant urologist in Leuven, and he's also the program director now in urology. Wally, lovely to see you. Thank you for joining us.
Hey, good evening, Declan. Thank you so much for having me on the show. I wish I could be there with you and Peter Mac. It's been such a long time, but at least I'm happy.
Do people over there call you Wally, or is it just an Aussie thing?
If we have international guests, they still call me Wally.
Yeah, I remember.
Actually, when Declan came over as a visiting professor, he called me Wally, and this is when all the students started laughing, and that was it. That was the end of my career.
It's just my mangled Irish accent. I just struggle to get around the what can I call you Wally? It's very disrespectful, but anyway, you'll always be Wally to me, Wouter.
Happy to be Wally, Declan.
And of course, your centre in Leuven, your mentors, people like Hein van Poppel, you took Hein's position when he stepped down, and Stephen Jonyo there in Leuven. You know, huge names in prostate cancer, huge names in pelvic lymph node dissection. So we're delighted to have you on to talk to us about this topic today. But first of all, Renu, I suppose we should go and ask Karim to take us through the paper a little bit.
Yeah, that would be great, Karim, if you can give us the highlights of the paper and the lead up to developing this trial and what you found.
Absolutely. My pleasure. So this trial stemmed from exactly this very controversial debate that we have in urology, especially in the treatment of prostate cancer, is the value of pelvic lymph node dissection while we're treating prostate cancer surgically. And for a number of years, the thought process was that the more nodes we remove, the more positive node we find. And then that kept feeding into the thinking that we ought to remove more nodes so we can remove those micrometastatic disease. And then the thought process went into, if we remove those micrometastatic disease, therefore we are cleaning the pelvis and the outcome has got to be better.
Yeah.
But yet there is no evidence to refute or support that thinking. It makes sense to us surgeons because we believe that in removing disease, we make a difference, but we have yet to put some high level of evidence to test that thinking. The counter argument is that cancer could have its prognosis determined biologically, regardless of our surgical intervention. So then we embarked on designing a clinical trial, a large trial of about 1,500 men that will be randomized to either a limited or an extended pelvic lymph node dissection. Memorial is a center that has traditionally believed in the extended pelvic lymph node dissection from the dictum of surgical oncology. And so the trial, initially we started with a 1-to-1 randomization of patients, but you can imagine the challenge when you have surgeons that are doing 2 or 3 prostatectomy a day for 3 times a week. That was a bit challenging to sort out. So then after about 70 some patients, we switched to a cluster randomization of surgeons. So surgeons will be randomized every quarter to either a limited or an extended pelvic lymph node dissection with permutation. And so with that, we were able to successfully accrue to this trial, and we accrued close to 1,500 men. Nearly half of them were randomized to the extended pelvic lymph node dissection, which includes, there is a lot of difference in semantics about what is an extended, what is a standard, and so forth. So papers tend to overlap on this definition. For us, the extended meant removing the external nodal packet below the external iliac vein and above the obturator nerve, the obturator fossa, and the nodal packet along the branches of the hypogastric or internal iliac artery. So from the bifurcation of the common iliac onto the branches all the way to the pelvic floor, and that's what we call extended. The limited pelvic lymph node dissection, which Renu and Declan actually is nowhere in any urological book described anatomically as a limited, is something that we sort of grew into performing and calling a limited. It's one of those things that we know when we see it, but it's not written anywhere or defined anywhere, and is a product of PSA screening. So the limited is basically the area below the external iliac vein and above the obturator nerve. Okay. And so before we started this trial, we sat down all the surgeons at Memorial that are dedicated to prostate cancer surgery, and we reviewed our semantics. And believe it or not, we had some differences. And we reviewed each other's videos to make sure that what we are speaking about is standardized within our group. Then we embarked on the pilot phase of the trial and then started the randomization trial. This trial, I must say, is clinically integrated, which means that there is very little, if any, that is research driven. Most of our clinical practice, we basically treated patients with prostate cancer the same way whether they are in the trial, randomized and enrolled in the trial or not. And so at the end, it's a large trial, but it's also something I would like to say is a low-cost surgical trial.
Yeah.
And so what the primary endpoint of this trial was biochemical recurrence rate, and we powered the trial at 90% power with an expected recurrence rate of, at 5 years, of 20% biochemical recurrence between the arms. So we embarked on the trial, and the results showed that both groups, in terms of clinical and pathological features, were quite balanced, and that there was no difference in biochemical recurrence rate whether we did a limited or an extended pelvic lymph node dissection. Mm-hmm. The hazard ratio was, whichever way we looked at the data, sensitivity analysis, 0.99 or 1.1. Mm-hmm.
Yeah.
So literally no difference.
Yeah.
It must be said that when you look at the data, what we found is that the difference in number of nodes between the limited and extended was not as big as we imagined it to be or planned it to be. We were expecting that perhaps the average or the median number of nodes removed in the limited would be 8 or less, but it was a little bit higher than that. And the extended was exactly where we wanted to be. And so I think that speaks to the fact that conducting surgical trials, surgical randomized trials, are quite challenging. The surgery, dosing the surgery is not like a pill. And there is a huge body of literature from the UK about this, the fact that even if you do audits, it is impossible to audit every operation in every operating room in 1,500 times to make sure that what happened in the operating room is done. And I've read that a paper where the surgeons were given a survey to fill out, sort of a checklist after, to say what they truly did. And there was a little bit of disconnect between what the surgeons said they did and what actually did happen in the operating room when we talk about templates and anatomical limits and so forth. And so I think the Japanese came out with a checklist for their randomized trials for lymphadenectomy and gastric cancer just for that purpose, because it's quite challenging to constrain and to have precision in what the care that is delivered exactly when we talk about lymphadenectomy.
It's a great point, and we totally agree. And I think the biochemical recurrence-free survival, the primary endpoint, very, very interesting. But I wanted to ask you more about the lymph node yield, because, you know, I agree with you. The standards, the limited node dissection, just the external iliacs, you were getting a median of 12 nodes.
Very impressive for
I can tell you that
dissection.
if I was only doing external nodes, I would be getting 4 or 5 in our pathology department. Yep. So there's surgeon heterogeneity, but there must be pathology heterogeneity. But have you an answer for that? 12 just seems extraordinarily high for most people around the world if they're only plucking out the external iliacs.
Yeah, I think I prefaced the introduction of this paper by saying that Memorial's tradition is to believe in the extended pelvic lymph node dissection, and most of us trained at Memorial and are on faculty, and I think we had to teach surgeons how to do a limited pelvic lymph node dissection, and that comes exactly to what I'm saying is when you have been trained and have been performing for a number of years an extended lymph node dissection, there might have been a bit of a discomfort or doing something smaller than that.
And that's very interesting, Karim, because you're right. It is when surgeons are used to doing a certain template, it's very difficult for them to be more limited for the purposes of a trial. But one way to control it, and we'll talk about this more, is to randomize to no dissection versus some dissection.
And maybe we'll come back to that in a sec. But before you do that, I also noticed in the paper that Karim and colleagues reported that I think a couple of studies a couple of surgeons discontinued participation for that reason. Is that right? Or there was some comment in the paper about, I think, 2 surgeons stopped participating in the study, and it didn't say exactly why, but I'm speculating that that's the reason why. It's like, oh, come on, with the best will in the world, the problem is, well, now you can see the obturator nerve, so that's no longer a standard, a limited dissection, and this is human nature, I suppose. But so you think that that's probably a factor, isn't it? That although the protocol said this, it just takes a little centimeter extra means there could be 3 extra nodes there, I suppose.
That's right.
Right. And I think that's one of the reasons. And we did a lot of sensitivity analyses that are in the supplementary of the paper, because we looked at, will surgeon enroll more patients when they are, because they know this is not a blinded trial. They know every quarter surgeons receive an email that says you have been randomized from January to March to an extended. Or was there some cherry picking in a sense that if they are randomized to the limited, they were more likely to not enroll patients on the trial? We also looked at if they are randomized to the extended, are they more likely to include patients? Or if the patient is a high risk, are they more likely to invite them to participate in the study? But look, we always worry about that. But when we looked at our data and we ran our analyses, we did not see a huge difference. Yeah. So there wasn't, and I applaud my colleagues that participated in this trial. This is not an easy trial because you're asking someone to do something different than what they were brought up to do.
Absolutely.
And there was very little to no bias that would statistically affect the results of the study, which reinforces the idea that perhaps if we came up with that hazard ratio, whichever way we did, even after taking the surgeons that had some issue with the trial and looked at the trial without their participation, and they had very little patients enrollment anyway, the hazard ratio was still hovering around 1.
Yeah. And we have your colleague, Dr. Andrew Vickers, eminent statistician, as senior author on the trial as well. So, and I know he went through that in great detail. Well, shall we throw to Wally and see what?
Let's see what Wally has to say.
What do you think, Wally? No difference in biochemical recurrence-free survival whether you take more nodes or less nodes. There you go. It's not that surprising, is it? And we'll talk about the morbidity, of course, in a few minutes as well.
Well, as you know, Declan, it's a topic we've discussed before frequently. When I arrived in Melbourne, I was also trained in Leuven, where we also get trained to do this proper extended lymph node dissection every time. Then I came in Melbourne, and I know that there you guys don't like the lymph nodes so much. And actually, I was looking at the evidence, trying to convince the people in Melbourne to do lymph node dissections. And the more I was looking at the evidence, the less I was let's say, a believer of doing lymph nodes, and at least now we don't have to believe anymore, but we have some data. And I, first of all, let me say that I congratulate the team of Dr. Touijer for doing this trial, because it's a very nice surgical trial. They recruited 1,500 patients in 6 years. I like the pragmatic design integrated in clinical practice. I think you need a very good electronic health record system to do that, and it's something we've been working on too, because I think this is a very good way to run these trials. So congratulations on that. It was well designed, and I think we can believe the outcome of the trial. So that's important. Yeah. I was not surprised to see that there's no difference between doing lymph node dissections or not. Also, because if you look at other tumor types, we see exactly the same. If you look at extended versus limited, in breast cancer, in melanoma, in gastric cancer, in rectal cancer, pancreatic cancer. There's even trials comparing lymph node dissection with no lymph node dissection in ovarian cancer, endometrial cancer. And so in all these cancers, harvesting the lymph nodes does not change the clinical outcome. So why would it be different in prostate cancer? That being said, I think probably it's all about patient selection, of course, and there might be a subpopulation of patients who we might benefit doing a lymph node dissection, but it's we can talk about this more finding the right population to do your lymph node dissection. And I know one of the critiques on the paper was that many of the patients that were included were more at the intermediate risk end rather than the high risk end. And so the number of positive lymph, or the number of patients with positive lymph nodes was around 14% in the extended lymph node group. So maybe if you would have included more high-risk patients, maybe results would have been different. What I found,
or not, yeah,
or not, of course, sure. I guess if you include too many low-risk patients, probably your results get diluted. If you include too many high-risk patients, probably you have a lot of patients with already M1A disease, and the lymph node dissection doesn't matter anymore. Who knows? And then finally, I think the primary endpoint. We should discuss. I mean, here we don't see a difference in biochemical recurrence. So this shows that there's probably no oncological difference between both groups. But what would have been the conclusion if there was a biochemical difference? I mean, would this mean that then our patients would have better overall survival outcomes or cancer-specific survival outcomes? Because, I mean, we might just well salvage them by doing a salvage lymph node dissection if we don't do it during the operation. So there, I think the endpoint of biochemical recurrence is something that's I'm not sure if it's the ideal endpoint.
That's a good point because, I mean, as we've seen in some of the editorials written, is that biochemical recurrence is influenced by many things, not just lymph nodes, but also margin status, aggressiveness of the lesion. How do you think that influenced your results, Karim?
Well, in a randomized trial, it doesn't matter because in the essence of the randomized trial, margins should not be different because both groups will be the same. The surgeons are the same it's balanced on each side. So
in a big study.
In a large trial. And so it would not make a difference. It is clear that biochemical recurrence is a soft endpoint from an oncological standpoint. We want to look at difference in metastases. But you can imagine that we would probably be having this podcast probably 7 years from now, if that were that, and we will still continue on that. We were looking for a signal in terms of biochemical recurrence, because usually if you look at our paper that we published in European Urology about the natural history of men with positive lymph node treated with surgery alone, where we found that about 28% to 30% remained free from biochemical recurrence at 10 years. If you look at the curve, most of the recurrences happen within the first 3 years. There are few laggards, but the bulk of the patients, if that with node positive, if anything is going to happen in terms of biochemical recurrence, happens within the first 2 to 3 years, including those that will have a persistent PSA after the radical prostatectomy. And to Walter's point, I've been thinking about this for a number of years, this issue of lymph node dissection. And naively, when I saw that in the first paper that 30% of the patients remained free from biochemical recurrence at 10 years, I go, well, that's because surgery was good. I am not so sure. Maybe biology was different. Yeah. But if you look, node positive patients are quite a heterogeneous group of patients. And if you look at that group, those that are high risk disease or very high risk disease, I think the prognostic power of a positive lymph node modifying the outcome gets diluted by the Gleason and the stage of the cancer. So I don't think in those patients, a lymph node dissection would have a huge impact. In the low risk or the favorable intermediate risk, I don't think that's nothing. There's nothing happening in that group. If I were to hypothetically think about a sweet spot, it would be those with intermediate risk, where if the question that a lymph node dissection might make a difference or have an impact, that would probably that group of patients that would be the right group. And if you look at the overall population of node-positive patients after radical prostatectomy, the majority of them are intermediate, probably unfavorable intermediate risk. Because overall, the proportion of high-risk patients, at least based on the last 10 years, it may change in the future since surgeons have been including high-risk disease more often in their indications for radical prostatectomy. I think that intermediate risk is not a small group, and it may be the group that is prime for studying this question of radical prostatectomy, of pelvic lymph node dissection.
Totally agree with you. And before we want to move on in a moment, talk about where next with this, and obviously we want to talk about PSMA for staging and all that. And but before we move off the trial, Karim, complications, morbidity is always something we want to think about with this as well. We have a systematic review in European Urology, not that long ago, showing that pelvic lymph node dissection does not improve survival and does lead to increased complications. So for me, that's always the question is, yes, there's value in the staging of it, but what about the morbidity, Renee? We were just talking about this with Wally before we went live, weren't we?
Yeah, I mean, it's always disheartening when you get 4 or 6 nodes, but the patient has a big lymphocele that requires a drain and
lymphedema,
lymphedema,
negative nodes. Yeah, exactly. So complications in this study, very well monitored prospectively. I think 7 or 8% had up to grade 3 complications. Can you talk to us a little bit about that? Like in a very high volume center that does a huge amount of safe surgery, these are good numbers, but can you talk to us a little bit about that from the trial?
Yeah, so we looked at complications, and we also looked at difference in recovery of sexual function. And I can tell you, sitting at a conference, and one of our surgeons showed the video of the radical prostatectomy, and he was working around the obturator fossa, and somebody said, "Oh, you're using too much cautery. You're going to burn the nerves in there." And somebody says, "Well, we'll have to see Karim's trial if there is any difference, or is that something just a worry and things that we do?" And that's the beauty of these randomized trials in surgical technique, is they really, they're sobering. And so we wanted to see, because the part of the lymphadenectomy where we are right lateral to the plexus and to the neurovascular bundle is when we are removing the obturator fossa nodal packet. And we didn't see any difference in recovery of sexual function, whether we did a limited or an extended lymph node dissection. But to your point, the rate of complications was remarkably low in both arms, but was exactly the same. And we had an exhaustive list of any complication that happened. And so it's a good thing that we did not see a large rate, complications rates in this series. It's a good thing also that we didn't see any difference between the 2 arms. And the most common complication, as Renu said, are symptomatic lymphoceles, because I am sure there are a lot of lymphoceles that are undiagnosed because they're just not ringing the bell and they're not bothering anybody. We call them post-surgical changes. But when they are symptomatic or they are infected or compressive to the nerve, then we are alerted by them, and we image those patients and establish a diagnosis and treatments. Venous thromboembolic events are also higher in men that had the lymph node dissection, but luckily the rate of those is less than 3 or 4% overall. Some nerve injury, especially on the anterior and lateral thigh, where there is a bit of loss of sensory loss for 6 months or a little bit more, but that's reversible. Lymphedema was quite low. I don't think in this series we've seen anywhere higher than 1%. And that's because we do not dissect the lymph nodes that are between the external iliac artery and the genitofemoral nerve.
Yeah,
and I think, extending the dissection there would subject patients to lymphedema. Forcefully looking for Cloquet's node and digging Cloquet's node from under the inguinal ligament could lead to suprapubic or upper thigh lymphedema sometimes. But of probably very little value in prostate cancer.
Totally right.
And that's the bottom line, isn't it? Really weighing these morbidities with the oncological benefit.
So where do we go, Wally? We have a randomized trial, very highly powered, very experienced surgeons doing this trial. We can talk a bit about the node count, et cetera, but basically no difference in biochemical recurrence-free survival. The two areas that I think are most topical for us in this area remain: what about lymph node dissection at all? Is there any value? Or are there, is there a smaller set of patients that might benefit, as Karim was sort of hinting at? Because if you stick to nomograms and you think, okay, EAU guidelines say greater than 7%, but you could do a lot of lymph node dissection in men to pick up the 7%, and 93% have negative nodes and a big operation they don't need. It just seems like something that doesn't happen in most other areas of oncology, where we have sentinel guided approaches in breast cancer, in melanoma, in penile, etc. I honestly think we'll be looking back in years to come thinking, what were we thinking doing bilateral extended pelvic lymph node dissection in people with a 7% predicted thing with no sort of image guided approach, etc. But so I want to throw that out to you to say, how are we going to move from nomogram based stuff to a more maybe image guided or molecular guided? And the second thing, obviously PET imaging and so on, that you have a lot of experience with as well in Europe. So where do you think we're going with this currently in 2022, and what are the trials that are ongoing or that should be done?
Well, first of all, I think with these new results, it's something I really discuss with the patients before I think, first of all, we do less lymph node dissection than we did before. And I think as you say, we're moving the indication for doing lymph node dissections with these preoperative nomograms. Also there, I think we're doing less systematic biopsies. We're doing more target biopsies. So also the nomograms need to change, because all the nomograms are still based on systematic biopsies. And we just made a new nomogram where we try to predict the risk of lymph nodes based on DMR and DMR targeted biopsies. So that's one. Second, I think we have to go to higher percentages and only do lymph nodes if the risk of lymph nodes is higher, 10, 15%. And of course, I discuss this with my patients. I might do a procedure that has a 10% chance of finding lymph nodes with 90% chance of finding nothing. I do discuss lymphedema with my patients, and I have to say I was a bit surprised about the low rates of lymphedema in your study. If I look in our series, about 20% of patients have lymphedema, and about 10% of them even get sent to our physio for having therapy there, even while I try to preserve the most lateral nodes myself. So I try to discuss it with my patients, and if they say, look, I'm afraid of having lymphedema, or no, I want to have the lymph nodes, it's part of the discussion, just as you discuss having a nurse sparing or a non-nurse sparing surgery. Talking about trials, I guess we now need to do the trial of lymph nodes versus no lymph nodes. I actually applied for funding several times. Unfortunately, it wasn't granted at the moment. Having seen now Dr. Touijer's paper, I think maybe we should try to make it a pragmatic trial and try to do it cheaper than what I proposed. On the other hand, there is currently a trial open in Switzerland, the SAC trial, where patients with intermediate and high-risk prostate cancer get randomized between pelvic lymph node dissection or not. Primary endpoint will be biochemical recurrence. So we actually might try to join this trial, because I think this will give us, hopefully, an answer whether we should still do these lymph nodes or not. And then finally, Declan, of course, as you said, PSMA is coming, and you showed in the pro-PSMA study that doing PSMA pre-surgery will give you better staging. In Belgium, we have a lot of access to PSMA. The staging PSMA is not a reimbursed indication yet, so we don't do it so much as you guys are doing it, but still we do it. I think at least we can spare lymph node dissection in some patients, patients that have metastatic disease or in PSMA. We don't have to treat them with surgery. We won't treat them with surgery. The question is, what do you do if you see a positive lymph node on the PSMA? Would you then go for radiation therapy, or would you do the lymph node dissection first? Something we haven't discussed also in the paper is, what do you do, Dr. Touijer, if you find a positive lymph nodes in your lymph node dissection? Do you give all these patients adjuvant radiation to the lymph node regions? So I think PSMA will help us to better select patients, but I think it's too early to really say if I mean, how this will impact our outcomes and if this will improve our outcomes or not.
And the practical reality, as we often discuss, and we don't want to wade all the way into the PSMA stuff, we'll be here for the whole rest of the day, is, you know, in a place where you have a lot of PSMA, in countries where there's a lot of PSMA, what do you do with the negative PSMA PET scan? I can tell you pragmatically, in Australia, last 6 or 7 years, it will very often mean patients are not getting a lymph node dissection, even if their guideline might say, or their nomogram might say it's a 7% or 9% predicted thing. We still need to integrate PSMA PET value into nomogram prediction as well. So that's an ongoing thing. You know, myself and Alberto Briganti had a great debate at EAU last year about that whole topic, and we both acknowledge it's ripe for research. What do you do with the PSMA negative patient? You know, de-escalate the selection for lymph node dissection. But the other thing I think within that is novel technology like PSMA radio-guided surgery, you know, injecting a PSMA ligand, using a probe to identify PSMA avid nodes. So rather than just blindly taking out, you know, an extended template because of the nomogram, you may use something like an acoustic PSMA probe or visual, but preferably acoustic, to sort of, you know, enhance the likelihood that you're going to pick up a positive node and maybe decrease the amount of node dissection. It'll all depend on accepting a certain amount of negative predictive value, et cetera, et cetera. But I think, Karim, that's where we'd love to see it going, using better approaches rather than blind nomogram driven approaches based on important but old data now from a different era, to try and, you know, enhance the number of patients who might benefit from a node dissection. I don't know what you think about that, but the other thing I'll say on PSMA as well is that what you'll see on PSMA a lot, unfortunately, is nodes outside the template. You'll see mesorectal nodes, especially. You know, you never see on a CT. You got these 4 millimeter. Well, holy moly! I mean, that looks like it is a positive node actually. There it is, mesorectal. Hence why extended pelvic lymph node dissection doesn't improve survival in large data sets, because of course you're sometimes going to. It's not always draining into the classic template. It's draining elsewhere. That is the nature of prostate cancer, I think, as well. But your thoughts on PSMA as we head towards the end, and how we integrate it into trials, I suppose, as well as use it in current practice.
What a wonderful talk with you guys. We can stay here talking about this for quite some time. So I am pleased to tell you that the lesson learned from this trial is the trial that we started about 1.5 years ago of pelvic lymph node dissection versus no pelvic lymph node dissection. Yeah. Same design, same size trial, same low-cost trial, and it's accruing. We are down about 500 patients already, and the accrual is going quite fast. Now, that's on the side. And Wouters, if we would love for you to join us on the trial. We're opening it to different centers, so all are welcome.
Thank you. Would love to.
And with the issue, Declan, you brought this issue of, for a number of years, we've been bound by the anatomical template. We know that 35% of the positive node are outside of the template. PSMA, with its beautiful specificity, I think is a game changer in both ways. It's an improvement, and it's going to give us surgeons the runaround, because it's going to show us these very specific nodes, Declan and Renew, that are in the mesorectum. And they are very difficult to find. We're talking about 5-7 millimeter in the mesorectal, an area that is literally almost impossible to find these nodes just with the naked eye.
Yeah.
And it's going to guide us. It's going to open. The PSMA is going to take us away from this tight anatomical template of draw the line here, and this is where you need to remove the nodes, to an image-guided surgery era, where we can either make the cancer glow or make a sound like a Raman photoacoustic or a Cherenkov signal, or the old gamma probe and looking for a radio-labeled signal that of radioactivity that can guide us to these nodes. Because prostate cancer, now that what the PSMA is telling us is, can go directly into the presacrum, can go directly into the area just outside. That's what's frustrating, is that you see recurrences, nodal recurrences, they're happening just few millimeter to where you were doing the surgery, the area medial to the hypogastric artery, the mesorectal, the presacral, and so or even in the periprostatic fat. And so we have, I think, the PSMA has shed a light on something that we didn't see before, and it's gonna make us think about the trials we want to conduct and introduce technology to allow us to be a little bit more sophisticated in the operating room. But the question that still hangs on our head is removing these nodes still makes any difference, and we will know in a few years.
Fantastic.
Right.
What a great way to finish up. Renu, last comments from you.
No, I mean, it was a great talk. The only other thing we should mention is the other prospective randomized trial that was done last year, and that was by Dr. Lestingi and his team from the University of Sao Paulo in Brazil. Much lower numbers than yours, Karim, only 300 patients, randomized to limited versus extended groups. Again, the templates were a little bit different, but the median nodes much more different. It was 3 versus 17 in the extended group. And again, they didn't meet their primary endpoint of a biochemical recurrence-free survival advantage. But they did a subgroup analysis of high-risk patients, and there was a trend towards improved biochemical recurrence in the high-risk group. But I mean, one takeaway from yours, Karim, is that at least a limited node dissection is not inferior to an extended node dissection. How's this going to change your practice, if at all?
And so it has changed my practice in terms of running the trial of lymph node dissection versus no lymph node dissection.
Yes. Yeah.
And I think the Brazilian trial that you spoke about from Sao Paulo is a limited versus a super extended. They included the presacral, the common iliac, and still with that much difference, still there is no difference in biochemical recurrence.
Yeah.
The term trend, it makes me a little bit uncomfortable. To me, every time I see a paper that speaks about it, we saw a trend, it's a wish.
Yeah.
But the reality is the mathematics.
I totally agree. Let me rephrase it. You mean there's no difference?
There's no difference.
Exactly. And I know Andrew Vickers would say the same. Don't you mean that there's no difference? Yeah. Especially on a subgroup analysis, isn't that right? Yeah. So look, I totally agree. And look, I think hooray for such a fantastic surgical trial. More surgical trials, please. Isn't that one of the key messages? And by integrating it into clinical practice as you've done, I think that's what Wally was hinting at as well. That's got to be the way. We need to design pragmatic trials that we can do in surgical practice, which at least make them recruitable and achievable, even if we're still bedevilled by surgeon heterogeneity and the other factors you spoke so eloquently about earlier on. But look, congratulations, and I think that next trial, the son of this trial, is the one that will really, really probably either put the nail in the coffin of widespread use of lymph node dissection, or maybe will make us just rethink again about the value. And I wish you all the best with that, Karim. And thank you again to you and to Wally for joining us today.
Thank you for having me. Pleasure to meet you, Renu.
You too. What a great chat, Declan. We should have more surgical podcasts.
I know, yeah. In fact, that should be our mission for 2022. 22. Yeah, 22. Yeah, that's what we're going to do. We're going to do more surgically oriented podcasts for all those keen surgeons out there. So great. Thanks very much for joining us, everyone. We wish you all the very best. Hope you enjoyed that. If you have suggestions for other topics we should cover this year, please do get in touch on Twitter, or you know how to track us down pretty easily. Thank you very much, and goodbye.